Hello, Dr. Pimentel here. I'm one of the physicians in urology in Grand Rapids here. If you're watching this video, you're dealing with a kidney stone, and unfortunately, you're trying to figure out what kind of options there are to deal with this. So we have as many options as kind of bigger surgeries where we keep you for a hospital stay to non-invasive procedures, as well as sometimes even the best option is just to watch it. So I'll be giving you about a 15-minute presentation on all these different options and the treatment options, the risk and benefits of them. That way you have a little bit of time at home before we meet in person to kind of formulate questions that you may have, and also get a general idea of which option you think is best for you, so we can kind of target that one more if you feel one that you really think is going to work best for you. All right, we'll get started here right away then. So this is a little bit of a kind of some slides that we have here for you to get kind of the general gist of the idea of what we're going to be doing and what you're dealing with. So the kidney stones typically are kind of classified in two locations, either the kidney or the ureter. And the ureter is a channel between the kidney and the bladder. So that's the most narrow portion. That's the portion where they usually get stuck and give you a lot of trouble. They can give you pain and discomfort in the kidney, but typically not. It's a little less likely. Maybe 10% of those stones rust. In the ureter, at least 90% of the time while they're on the way out or in that part of the channel, you'll have pain, at least 90% typically. Some people, even with big stones, will not have pain though. So like anything, there is some variation. The size of the stone as well as the location, those are kind of the two big markers and what we want to do. So if we have a small stone that's less than 2 millimeters, they usually pass at least 90%. So we like to watch those at least a couple weeks, typically about a month. After a month, that's typically telling us that the stone is maybe just hung up on a little inflamed area. It's a funny shape and it's kind of hooked into the lining there. And the chances of it passing after a month do drop quite a bit. Although it's very safe, even if your kidney's blocked, to give it a month to 6 weeks to pass the stone. That's a very reasonable amount. That's usually what we try and go for these stones in the 2 millimeter to 7 millimeter range. So it is a gray zone. Obviously 3 millimeters, about 80%. A 7 millimeter stone is likely to pass maybe 50% of the time. So it just slowly drop. Once you get to about 8 millimeters, you're talking about less than 40%. Still a decent amount of those will pass. So even people with 8 millimeter stones, as long as it's not really block shape, you have a pretty decent chance of passing them. If it's 8 by 2 by 2, it looks kind of like a bullet shape or an eraser. Sometimes the stone can kind of move around in a more favorable kind of position and slide out. So we usually give stones less than 8 millimeters, at least a few weeks typically, as long as the pain's tolerable, you don't have fever or chills. If you have fever or chills or you can't control the pain, the pain's just unbearable, then usually we recommend going directly for stone removal. Any stone that's 19 millimeters, so that would be about an inch. So 19 millimeters, almost an inch, we need a special operation, which we won't discuss too much here, but that's kind of our breakdown there. So. And these are the locations. So here you can see this is the outline of the kidney on the outside. This is actually the hollow portion where the urine collects. This is dye into the kidneys all the way into the bladder. You can see very easily here how in the kidney there's kind of a lot of space for the stones to get stuck. And between here and here, it's a nice narrow channel. You can see why in the ureter we call this area here. Before it gets to the bladder, it very easily gets stuck there, and usually that's where you get pain. So that's kind of what we're dealing with there. Once it gets in the bladder, the channel from the bladder to the outside world is typically about 3 times bigger than the ureter. Even though it looks narrow, from the outside, it's very stretchy. So once it gets into the bladder, you're usually home free. The type of stones do matter a bit. Most stones, about 90%, maybe 92% or so, are in the calcium. They're harder type of stones, and they're easier to see on x-rays. Uric acid are unique in that we can't really see them on x-rays, so we have to get a CT scan, which is a very special group of x-rays. It's basically a bunch of x-rays that are taken together, and a computer is used to kind of get a three-dimensional view. The third type of stone is an infection stone. Those are also very hard to see. They're usually soft and often not seen easily on x-ray, so usually we need a CT scan or ultrasound as well for those. CT are pretty rare. We won't get into that too much. It's maybe one in 1,000 people might have that particular disorder. You'll know if you have it. Most people who form cystine stones have a genetic disorder, and you'll get stones all the time. It's a very intensive management for that. So what are the goals? Number one, obviously relieve pain. If you leave the kidney blocked for more than 6 weeks, you can start getting permanent damage. So you got 6 weeks, which is quite a while, but you want to do that and prevent infection. If you have a blockage and an infection, that's an emergency, and that really needs to be taken care of, through the emergency room, kind of within a day or so. If you're the first 6 weeks, if we're trying to let the stone pass, we usually give people plenty of hydration. We tell you drink 3 liters of fluid a day, which is about 100 ounces. That's a good target for the average, person that's, 5'5" to 6 feet tall, let's say. If you're a little bigger, a little smaller, you can adjust that and obviously do your best. If you can't drink that much fluid, do your best. If you can only do 80 ounces, that's fine. We recommend people to stay hydrated because being not hydrated enough does hurt you a bit. But certainly once you hit 3 liters, it won't help you to drink, 2 gallons. It won't make a difference. It's more of are you adequately hydrated or not? We give a medicine called Flomax or tamsulosin. It's the same medicine, different names, and that helps pass the stone a few days faster. Ibuprofen is probably the best pain medication we have. Ibuprofen is the same type of medication as Aleve or Toradol, so those are all equally alternatives. We just don't want to take all of them, those together, because they're the same basically medicine. So you got to pick one of them. We usually go for ibuprofen because it's one of the cheaper ones, but Aleve, Toradol, or ibuprofen are all excellent. They tend to relieve a lot of swelling and pain. And of course, Tylenol. I would take Tylenol as well, usually 1,000 milligrams. Just like the ibuprofen, 3 times a day. You can take that staggered, or you can take them at the same time. They're both safe to take together. And sometimes we do obviously give people some narcotics as well. If those two don't help, along with the Flomax, like oxycodone, Norcos, things like this also can help quite a bit. We try to stay away from those if we can, because ibuprofen is usually the best one anyway. And once you get to that point, it's probably time to start working on getting surgery to get the stone out. You don't want to be on those medicines for too long. You'll get constipated, you'll get woozy, you can't drive on them, and about 7% of people get addicted to them, no matter how much you want to avoid that. So it's important to strain the urine. For the first 6 weeks, you want to use like a coffee strainer. You can buy them like at the dollar store if you want as an alternative. We will usually, through the emergency room or in our office, give you a strainer, which almost looks like a colander, but a very small version for the like the pasta strainer. So you pee through that, and if you see anything that's like a pebble, you can put into a little Ziploc bag or a little cup. We often give you little specimen cups for a container. It should rattle in there. It should be it's usually a pretty firm substance. If you see kind of like blood or clots or a little material, that usually is not the stone. So we have to keep straining it if that's all you're getting. Typically also, we'll get another ultrasound or an x-ray or even a CT scan sometimes, one of those 3, to make sure that the stone is passed if we think it's passed, just to confirm that there's nothing left behind or a broken half and half of it passed, but not the other half is still there. So we usually will get another x-ray or ultrasound. That's why you might see another order for that afterwards, to make sure it's passed, and also to see what it looks like when there's no stone there on those tests, so we can kind of follow that later on if there's more issues going on. The first type of option that we usually use to remove stones is probably the most common. It's a little bit more painful as well, but it's a camera. As you can see there, we use a scope, so a little metal device or plastic that's very thin. It's about as thin as an IV. It's only about 3 millimeters wide, and it goes through, while you pee through, all the way up to wherever the stone is, and in this location is here, and we can use a little laser to break that up completely. The laser pretty much works every time. It's about 95% effective I would say usually with one procedure for me. A lot of people do place a stent beforehand, which is like a little splint on the inside here. There's a little curl, which is a temporary way to unblock the kidney. Then they go back a few weeks later and get the stone out. But that does require 2 surgeries if you get that done. It's more of a judgment call. But in general, with one attempt, I said I could probably get it out 95% of the time. Sometimes it is just too narrow the channel, and we have to do it in 2 tries. Or there's a little fragment left behind that we don't see afterwards, and it gets stuck on the way out. The big benefit is that it's very, very successful. We can get the stone anywhere, and multiple stones. It's about 95% versus 88% compared to the other option. The downside is that it is usually takes about 7 days to feel better, sometimes a few weeks, but usually about 7 days. I would say something like 20% of people do good right away. They can do anything within the next few days. But for most people, 3 to 7 days is what you're expecting. And then there's that other 20% on the other end of it that might take a week or 2 to feel better. There is about a 1 to 2% chance of causing scars either in the urine channel from bladder to the outside world or from the bladder to kidney in the ureter. So between both of those, you can get a little bit of scarring. So you're putting scopes into the body. So obviously there is some downside. And all of these options have the same risk of infection, not working, pain, but this is kind of the general gist. Secondary surgery needed, as you can see, 5% versus about 12% for the other one. The Shockwave, as you can see here, is much more doctor independent. So it's basically a machine. We lay you flat like this on a table. We put a machine, it looks like an x-ray, but this gel here, pad, attaches to the body, and it's like a little gel pad like you see with an ultrasound. This is the x-ray here. So between this gel pad and this x-ray, on the machine here, we put a bullseye over the stone on the x-ray, and this little pressure wave goes through the body and hits the stone. It's kind of like a wave in the ocean where the wave can go through water. Our bodies are mostly water, so it doesn't hurt us. It slowly gets weaker as time, but when it hits the stone, it's kind of like the wave hitting the shore. All the energy is released at the stone, and hopefully that thing turns to dust and you pass it easily. About 88% of the time it turns to dust and you pass it pretty easily within a few days to a week. But about 12%, you need a second treatment or we have to do the other option. The big benefit of that is obviously no scopes. You don't have to go through the urethra. There's no burning afterwards when you pee usually. It's less painful. About 88% of people would say it goes pretty smooth. And there's no scarring in the channel. The risk is that it's less successful. You have about a maybe 7-8% chance less success rate, which is significant. But if I had probably a stone in one stone in the kidney, and it's under 10 millimeters or less than half an inch, it's a pretty good option. I'd probably choose that. Although depending on what your personal preferences, the benefits versus risk, they're both very good options. There is about a 1 in a couple hundred chance of bleeding around the kidney. The Shockwave can tear some little blood vessels around the kidney and cause pain. That sometimes will last a few weeks, but it's pretty rare, 1 in 200. And if your stone is about 14 millimeters, or you have 3 or 4 stones, almost certainly you're going to require two procedures. It's usually less painful, but it does require 2 procedures, so that's a big downside, of course. So big stones. Once they get to be about half an inch or so, the stones, or you have 3 or 4 stones up in the kidney, you will require more than 1 procedure. So that's a big downside of that. And then the last option is the percutaneous stone removal, which is, for stones that are really large. And the reason, we won't go into this too much, but the reason why we go for this is because if the stone is, half an inch, if you can see here, it's about this big here, all the dust that's created with the other options almost certainly gets stuck on the way out, or it may not get stuck, but some of it will get stuck in the little other channels in the kidney and tend to reform again. So when a stone is that large, almost always you have some dust that kind of floats around, gets settled, and you might do fine for several years, but you have a little higher rate of that dust, becoming big again, snowballing into a stone. So this is kind of a big procedure. We make about a half-inch incision in the skin, go right through the muscle and into the kidney, and we're able to use a device that sucks the stone out. So that's why it's more effective for really big stones, because we're unable to miniaturize this device. But when we make a little bit bigger channel through the kidney, you can get that. Unfortunately, this procedure, you have to spend the night. So the other procedures, you go home the same day. This one, usually spend the night, a day or two. And there's about a 2% transfusion rate. So, it's kind of a different, it's for different category of patients. The big downside is about a 1% chance of hitting the lung. You can collapse the lung, that you need an IV in the lung, basically, to get the air out for like a few days, maybe a week. Blood transfusion, like we said before, and obviously a hospital stay. So those are the big downsides. Rarely you can injure things like bowel and spleen and liver, but that's maybe 1 in 100 or so, or less. And those are basically our big options. Everything is very dependent on your individual health records and need. So, for example, if you cannot stop blood thinners, we can't do ESWL. ESWL has to, blood thinners have to be stopped. Ureteroscopy, a lot of people stop it. I don't usually, but a lot of people I know will always want to get those stopped even with ureteroscopy, but you don't have to. So ESWL is limited. If you're unable to stop blood thinners, that's a big downside. There's a lot of little nuances like that you'll have to talk to us in person, of course. This is more of a general overview to really find out what's good for you, because there are certainly personal issues or challenges or medical conditions that you may have, which direct us to have to really individualize these options for you. Sometimes it's just specific nuances that will kind of guide you to a different option. So thank you very much for listening to my presentation here, and I hope that helps you kind of prepare for our discussion in person, and helps you kind of get ready and gives you an idea of what option you think is going to work best for you. You have a good day.